Good morning, and thank you to the Chairman for inviting me to give you this talk on mistakes to avoid when performing unicompartmental knee replacements. I'm only sorry I can't be there in person to join you. The only conflict of interest that may be pertinent to this is that I'm a faculty member for the Mako robot, although I won't be talking about robotics today. What I will be talking about is how to perform a unicompartmental knee replacement and avoid some of the common mistakes I've noted when revising unicompartmental knee replacements. So I'm going to talk a little about patient selection, failure rates, modes of failure, and some technical tips to hopefully prolong the longevity of your unicompartmental knee replacements. So here we are sitting in clinic with a patient who's before us and who is sad because they have a sore knee. And if they have unicompartmental disease, then we have a number of treatment options available to us. Amongst these are osteotomy surgery, unicompartmental knee replacement, or total knee replacement, and each has its own advantages and disadvantages, as we know. Compartmental knee replacement is an attractive option. It has less morbidity than a total knee replacement, and when performed well and accurately, has great patient satisfaction. The correct patient for me has bone-on-bone disease in a single compartment, has a functional anterior cruciate ligament, a correctable deformity, no significant fixed flexion deformity, and another indication might be avascular necrosis with an osteochondral fracture. And in the correct we have a good chance of making them a little happier. However, in order to do so, we need not just the correct patient, but also to choose the correct prosthesis and to perform the procedure with a technique which is going to implant that prosthesis in a way that's going to provide longevity and symptom relief. We know that revision can be a problem. In total knee replacement, the rate for the youngest of patients under 55 is around 8% at 10 years, but is around the 2 to 8 mark throughout the age ranges. For a unicompartmental knee replacement, one can look to doubling that rate of revision. And this is a particular issue, particularly for younger patients who may require more than one revision of their unicompartmental knee replacement if it goes wrong. There isn't very much to choose between mobile bearing, here in blue, and fixed bearing unicompartmental knee replacements, with, as we know, patellofemoral joint replacement having a higher revision rate. I tend to use a mobile bearing replacement if and when I'm not using the Mako robot, and this is the one I tend to use, and this is what I'm going to talk to you about today. So this is a mobile bearing design which relies on balancing the gaps in flexion and extension to produce symmetrical gaps. The microplasty instruments, a newer version which have been available over the last few years, have made this a much more reproducible operation. However, some of the errors that we see can also be carried over onto different types of implant. So the ways in which these go wrong are through malalignment, both of the implants and the limb. Here a knee that's been forced into valgus with overload of the lateral compartment and early failure. Instability, either of the ligaments or in this case with a mobile bearing, a dislocated bearing. Or loosening of the implants and collapse, which may be contributed to by the position in which they're placed. So malalignment of the implants can often be seen on the tibial component. So there's a little collapse here, but also it was implanted in a varus position. How does this arise? Well, here is our extramedullary cutting block, and we can see how this can be pushed off medially by the soft tissue envelope close to our incision and the patellar tendon on the lateral side. And if this happens, the axis of our cutting guide and the mechanical axis of the tibia no longer coincide, producing this varus alignment. We can note this proximally by a gap between the cutting block and its cutout for the patellar tendon and the patellar tendon itself. Reducing that gap will hopefully correct that malalignment. A secondary way to check the alignment of our cutting jig is to draw out the tibial crest, and I do this for any extramedullary jig I'm going to use. Now we have a visual check with the jig and the line coinciding and the jig now obscuring the line. We know that they coincide, that they are parallel, and therefore we will be parallel to the mechanical axis of the tibia, meaning that our cut will be orthogonal. Using these microplasty instruments also allows us to monitor the depth of the cut very accurately by judging it from the joint line, and this is a great improvement on the previous design. Removing the tibial cut in a single block means that we don't have to struggle to get pieces out from the back, and doing this in this meniscectomy position with applied valgus makes it a lot easier. Another mode of failure is through MCL injury, and this can lead to malalignment by forcing the limb into valgus. If we do injure the MCL, then the unicompartmental knee becomes impossible to balance, and rather than putting in a thicker polyethylene as was done here, really one needs to convert to a total knee replacement. The MCL is damaged at the time of tibial or femoral resection by the oscillating saw most commonly, and so it's really critical to have the retractor placed at the level of the cutting block to prevent the saw from penetrating the fibres of the medial collateral ligament or the overlying soft tissue envelope. Here for the tibial cut at the level of the tibial resection guide, for the femoral cut a little more proximal, more anterior, to protect the fibres at the level of the femoral resection. Medial pain is another mode of failure, and this can be contributed to by overhang of the tibial component. So here we have a tibial component which is abutting the overlying medial collateral ligament and is going to produce focal synovitis. If it does so over a period of time, then that may lead to premature revision. How is this contributed? Well, sizing is critical, and particularly in small Asian tibiae, you need to ensure that you have access to the smallest size of components. For this type of component, that would be a double A size, but also the positioning, both the sagittal position and the axial rotation need to be correct. Having the sagittal cut made abutting the anterior cruciate ligament fibers to give you maximum space for your implant is important. And if we look at this top-down view of the tibia, this is where we would like our component to sit. However, if we get the axial rotation of the first sagittal cut wrong, typically externally rotate, then that will lead to posteromedial overhang, and on the AP that will look like an oversized component, whilst in fact it's more accurately a malrotated tibial component. And where that overhangs posteromedially, we'll see focal synovitis and pain. Loosening can be another issue, and this is contributed to by the tibial resection. So here is our tibial guide sitting at the front with our saw blade. We're going to cut through the proximal tibia, and then if it hits hard bone posteriorly, the blade can skive, and as the cut is completed, leave a nubbin of bone at the back, so an asymmetric cut, like so. And as we are meticulous surgeons, we're going to note that. We don't want that to stop our tibial plate from being impacted down, so we're going to resect that extra bit of bone at the back. Typically we do that by lifting our hand and aiming our saw blade more inferiorly. As that advances, it's going to produce an asymmetric cut in the other direction, with now a potential void posteriorly. In turn, this void may lead to instability of our tibial plate, and as it's impacted, we may see this seesawing effect with the tibial plate lifting anteriorly and leaving a void in that position, which now potentially can lead to early loosening, particularly with loading and extension. And if you critically appraise your postoperative radiographs, you'll notice sometimes seeing this little gap anteriorly. A similar problem can arise with the posterior femoral resection. If one gets the angle a little wrong and skives, then we can under-resect posteriorly. Now it'll be difficult to get our trial femoral component on. It may not impact down far enough, leading to an extra tight extension gap when we come to gap balance. If, however, we're wise to this and we lift our hand, let our saw blade in order to over-resect, then we can leave a potential bone void posteriorly beneath the implant. And with loading inflection, this can lead to levering off of the implant distally and early loosening once again. So Too thin a posterior resection, difficulty in impacting on the trial, and overestimation of the corrective milling required for the distal condyle. Too thick leaves a potential void, and perhaps using a twin peg design may reduce the impact of this on the longevity. Other top tips are to ensure we get good cement penetration by impacting the cement down, pushing it in with a clean osteotome at the time of cementation. Beware of extra-articular deformities and metaphyseal varus. This can lead to placing your implant in an unfriendly mechanical environment. So templating the tibial cut to ensure that a good limb alignment is going to be achieved is a good idea. And critically evaluate all of your own x-rays to make sure the mistakes made on one patient aren't carried over to the next. So I think in summary, mobile bearing unicompartmental knee replacement can be very successful. It does require, however, meticulous surgical technique to produce flat aligned cuts, protecting the medial collateral ligament and balancing the knee throughout range. It's greatly improved with the new instrumentation, and certainly for a large cohort of my patients, it's been very successful. Thank you very much for your time.